So friends, once very poorly understood visual electrophysiology has now gained its popularity because of the newer computer hardwares and software. Electrophysiology is being related to many other diseases, and unfortunately many institutions they have VEP on the name of electrophysiology. A f- yeah, a full-fledged electrophysiology lab is confined to only very few centers. So our session will not only talk about the basics, we are going to talk about the basics of the electrophysiology, but to implement into your own practice. By the end of this session, you should be knowing about the subject and which patients should be subjected for electrophysiology tests. You know what are the tests, and you will be knowing what are the part of that test, that electrophysiology. So we have with us Dr. Bibhuti Bhushan, a medical retina person, Dr. Rahul Prasad, heading the RIMS Department of Retina. Dr. Bibhuti Kashyap is head retina unit of Dr. Kashyap Memorial Hospital. He'll be talking about the pattern ERG. Dr. Bharti Kashyap, director of the Kashyap Memorial Hospital, she'll be talking about the EOG, which is sparingly used. Dr. Nidhi Gatkar will be she'll be talking on the VEP, which is very frequently used. And I'll be talking on very important aspect of the multifocal ERG and full-field ERG. So we are lucky to have Dr. Subhadra Jalali. She'll be joining us very shortly. She has agreed to come and join with us, and she'll be answering all your questions. So at the beginning of the talk, let me tell you one thing, that ERG has two parts. Number one, the electrodes being put on the patient, and number two is getting the result and interpretation of the result. So I'll request Dr. First speaker, Dr. Bibhuti Bhushan, to have his talk. Dr. Bibhuti, please come.
Good morning, everybody. I'll be just introducing the very important electrophysiological tests, and I hope that by the end of my talk you'll have a fairly good idea of why we do electrophysiological tests and who are the candidates, when should we do it, and the subsequent speakers will be giving you the specific information about the different tests, and I hope by the end you will have a fairly good idea to absorb all the information that the subsequent speakers are going to tell you. We examine the eye. There are different methods of examining the eye, and they all give us, some give us anatomical information, subfunctional, but electrophysiology gives us the early and specific diagnosis. There is an International Society for Clinical Electrophysiology of Vision that recommends testing protocol and tells us when do we do these electrophysiological tests. Now, why electrophysiological tests are needed? It is to localize the problem in the visual pathway. Symptoms, history, family history, and clinical examinations have their own limitations. Night blindness may have many other causes apart from RP. Retina may look absolutely normal, but may not have any vision. The retinal pigment abnormality may not match the loss of vision. So, who are the candidates who should undergo these tests? When the symptoms are suggestive of known neurological or ophthalmological disease which require confirmation of the diagnosis, like RP, Best disease, multiple sclerosis, etc. When there is an unexplained visual loss, like in medical legal problems and defects associated with psychiatric disturbances or mental and physical handicap. In pediatric neuro-ophthalmic practice, it's very important, where media opacities prevent other clinical examinations like cataract, corneal opacity, and vitreous bleed. These tests are of immense help. And when the patients are on certain drugs like HCQ, ethambutol, tamoxifen, and phenothiazine, it monitors the health of the eye. In detection of the disease or carrier states of inherited visual disturbances like RP and cone dystrophy, it provides a quantitative assessment of the progress of an eye disease, and it assesses the retina and optic nerve function following trauma. The patients who basically need these tests are with inherited retinal degeneration. These are the cases where that we get the referrals for inherited retinal diseases, degeneration, and we have to perform full field ERG, multifocal ERG, and pattern ERG. In patients of glaucoma, we need pattern ERG. For ocular siderosis, full field ERG, retinal detachment, full field ERG, and VEP. In multiple sclerosis, the VEP, inflammatory ocular diseases, and then retinal ischemic diseases like diabetic vascular disease and vein and artery occlusion, full field ERG and multifocal ERG. And in endophthalmitis, full field ERG and VEP helps. When there is an unexplained visual loss, there is a failure to read the chart with no other abnormality, visual behavior is normal. In that case, we need full field ERG, multifocal ERG, pattern ERG, VEP. In post-traumatic visual impairment, pattern ERG, multifocal ERG, and VEP is required. In visual impairment with stress, multifocal ERG, pattern ERG, and VEP is of help. Basically, in electrophysiology, it records the membrane resting potential and the changes that occurs after the light stimulation. There is a transmembrane movement of ions in retinal cells, mainly sodium and potassium. It makes the cell hyperpolarized, that is more negative to the extracellular space than in the dark. In ECG, because the heart is beating, it does not require any stimulation. But in ERG, because the cells are at the resting condition, it requires light stimulation for the changes to happen at resting potential. The different tests are done for different abnormalities. For EOG, and the abnormalities in EOG, it detects the RPE resting potential. The pattern ERG, it detects the gross macular function. The dark adapted scotopic ERG is done for gross rod function. The light adapted photopic ERG is for gross cone function. The pattern VEP tells us about the macular ganglion cells. The flash VEP about the visual cortex, and multifocal ERG, it gives us the information about macular photoreceptors. It's a localized response. If we have to do multiple tests, then how do we start? We start with the pattern ERG. It's a binocular recording and dilatation is not required. Then we dilate the patient fully, and then we dark adapt the patient for about 30 minutes and do scotopic ERG. Then again patient is light adapted for 15 minutes, and then we go for photopic ERG. What are the origins of the waves that we get in ERG? The A wave, that is a negative component, it is generated by the photoreceptors, the rods and cones. The B wave is a positive deflection. It is generated by bipolar cells and Muller cells, predominantly by bipolar cells. Then we get a C wave also, which is a positive deflection following the B wave. The basal portion of it comes from the basal portion of the RPE. We get a few oscillatory potentials, which are the positive wavelets on the B wave, which comes from amacrine, horizontal, and ganglion cells. This is a diagrammatic representation that you can see. The EOG is the C wave that comes from the RPE, and ERG, it is from the rods and cones. The A wave is from rods and cones, B wave is from the bipolar cells, and oscillatory potentials from the amacrine cells. Now a little bit about full field ERG. You will get all the detailed information in subsequent talks, but full field electroretinogram is a mass electrical response of the retina to photopic stimulation, the photoreceptors to the inner plexiform layer. In pattern ERG, we measure the central retinal and ganglion cell function. Stimulation is by reversing black and white checkerboard. It differentiates the optic nerve and macular dysfunction, and it is recorded using DTL electrodes. There are different kinds of electrodes that will be explained in subsequent talks. The electrooculogram checks the change in the electrical potential between the cornea and the ocular fundus, the outer retina, and the RPE. It is recorded during successive periods of dark and light adaptation. The visually evoked potential, in this signal generated at the visual cortex in response to visual stimulation. It assesses the integrity of the visual pathway. It reflects the activity of the central visual field. In multifocal ERG, there is a simultaneous recording of the focal retinal responses. It offers direct, objective, and topographical mapping. It records a central 30 to 40 degree of retinal function. It is a cone-driven response, and the fovea, parafovea, and near peripheral photopic retina function can be evaluated. For recording, the ERG is recorded by measuring the potential difference between electrode 1, which is the active electrode. It may be a contact lens electrode. And then there is a reference electrode, which is applied close to the eye near canthus. And then the ground electrode. There are 3 electrodes. One is active, the other is reference, and the third one is the ground electrode, which is applied to the forehead. This is a very important chart that will be explained in by the subsequent speaker. You can focus on the top line, because these are the factors that we need to take into consideration when we are doing these tests. In which test the refractive correction is recorded is needed. The visual acuity is important in some of the tests and not at all important in others. Whether the pupil should be dilated or undilated, what should be the test distance, and whether the fixation is important or not.
Please try and conclude, Dr. Vibhuti.
So with that, I conclude my talk, and I hope the subsequent speakers will give you the information, and with this background you will be able to absorb most of the information. Thank you.
There are certain very important tables which is being circulated to you, like this table is very important, that gives you everything at a glance, that what should be done and what tests should be done. So our next speaker is Dr. Rahul Prasad. He will be talking on different kinds of electrodes of the machine, along with the glimpses of machine. The machine is one with different parts, and all these tests are done through that machine. So, Dr. Rahul Prasad.
Very good morning, and thank you, sir, for including me in such an important topic for our ophthalmology. Of course, it's a developing field in the retina. It's a very important investigation these days. So, continuing from where Dr. Vibhuti left, I'll be talking upon the machine and the electrode parameters. Now, to record an ERG, it's important that we understand 2 important factors. Number 1, the basic technology, and second, the clinical protocol. The basic technology includes understanding the electrodes that we use, the stimulation of eye by the light, and the electronic recording devices. The clinical protocol includes preparation of the patient, understanding the ISAF standard ERG, and finally, the analysis and the reporting of the ERG. First, the electrodes that we use. Now, there are basically 3 different kinds of electrodes that we use. These are the active, reference, and the ground electrode. The active electrodes are those electrodes that captures the stimulus from the retina and the surrounding. The reference electrodes are those electrodes that captures the stimulus from the surrounding, and then we have got the ground electrodes. The electrode stability is maintained by a good connection as it decreases the impedance. More impedance means more noise, and that leads to a wrong reading. Remember, electrodes have to be kept very clean to avoid infection, and also for its reusability, because some electrodes are very costly. And also, cleanliness also decreases the impedance. Now, for a good recording by an active electrode, we have to ensure that we use a non-irritating, non-allergic, ionic, conductive, non-viscous solution. Ensure a very good contact to ensure proper electrode impedance. Then, as prescribed by the ISAF, we should define both normal values and variability for our own laboratory. Now, the different types of active electrode include the conductive fires, foils, conjunctival loop electrodes, and the contact lens electrodes. Now, these contact electrodes are centrally transparent with an optical opening, works like a lid speculum, gives the best recording, and it is stable with the highest amplitude also. Then we have got the skin electrodes that are mainly used in children. The corneal ERG electrode consists of 2 types, the monopolar, those are jet contact electrodes, and the bipolar, that is the Burian electrode. But the most commonly electrode that we use are the DTL electrodes. Also, we have gold foil electrodes. The reference electrodes are incorporated into the contact lens speculum assembly when you are using a bipolar electrode, such as a Burian electrode for stable configuration. Now, these electrodes are placed near the orbital rim or the earlobe or near the forehead. The third type of electrodes are the ground electrodes, where we have got a separate skin electrode which is attached to an indifferent point and connected to the ground. Typical location are on the forehead or ear. Now, what is an actual electrical impulse? Remember, the active electrode, it captures the action potential and the impedance, whereas the reference electrode captures the only impedance. So if we subtract that, we get an actual electrical impulse. This is actually done by the amplifier or a signal averager. Now, coming to individual electrodes, the first is the ERG, those are jet electrodes. These are disposable monopolar contact lens electrode, gold foil electrode or polymethylcrate with lead wires. It's very easy to insert, but movement of lens during recording and absence of lid speculum contribute to the variability of the reading. It reduces possibility of eye infection. The only drawback is the gold plated itches off with time. Then we have got the Burian Allen electrodes. These are bipolar, again reusable contact lens electrode, the built-in speculum with lead wires, customizable to various sizes. These are ideal for testing infants. Reference electrodes are built into the electrode itself. The PMMA shows variable degree of blurring, so it's not suitable when we need ERG where full clarity is very much vital. This is usually used for a full-filled ERG, but remember, these are very costly electrodes. Then, the most commonly used electrodes are the DTL plus type of electrodes, which we are seeing in the picture. These are conductive wires, 50 microns, negligible mass, low cost and disposable. Convenient to use, and they give very clear images. No interference with pupillar optics. They have got a very reliable ERG recording, and they are well tolerated by the children. Then we have got the gold foil electrodes. When you cannot use a contact lens electrode or we don't want to anesthetize the cornea, we use these gold foil electrodes. The ERG amplitude will be substantially affected by these electrodes. It requires an adapter. Now, the other types are the reference and the black ground electrodes. Now, there is a color coding for different electrodes. However, different companies have different, but on most commonly that we use are active refers to the red color, reference electrodes have blue color, and the ground electrodes wiring are black color lenses. Now, for preparation, it is very important that we use a good gel that actually that has got a very good cleaning effect and can decreases the impedance. Now, which is usually used by a skin prep gel. Now, then for the cup of the electrodes have to be filled with gel that allow a better conductivity. 10/20 conductive gel is one such set. No financial inclusions. Now, coming to the amplifier, we have got two types of amplifier. One which has got a one channel, which has got an active reference and a ground electrode attachment. And this is the second two-channel electrode, which has got an active and reference electrode attachment. Test for one eye is usually done by using one channel, while tests for two eyes are used for two channels. Then coming to the machine consists of usually three parts. First is the computer monitor, which tells us at what stage the investigations are we in. And then we have got the stimulation part, which we have got the central monitor and the Ganzel field ball. The central monitor gives us about the pattern stimulation, and the Ganzel field ball sets up about the flash stimulation. Now, this is a side view of the patient showing how the electrodes are placed. Now, for a multifocal ERG, usually we close one eye and then we proceed with the test. The movable chin rest is to be placed in front of the monitor. The chin rest with the monitor and the fixation point as shown in the picture. Then monitor displays random pattern of the multifocal ERG, and which is further recorded on by the electrodes. Now, once that test is completed, we can move the patient to the Ganzel field ball. Then baby flashes are used for babies and unconscious patient. A closer view of the Ganzel field ball. When the test is not used, the movable chest rest is attached to other place which is not required. Now, this is a schematic diagram showing how electrodes are placed. Now, for a recording to the ERG, test procedure must be fully explained to the patient. As the test requires, pupil may be dilated freely. Remember, always note the size of the pupil. Patient are dark adapted in a dark room with an eye patch, and electrodes are attached with a dim red light in the room. Then start the test. Attach electrode and follow the guidance coming on the computer screen. Safety information regarding machines, remember, if you are using printer or external USB hard drive, it should be connected to a Wi-Fi. Automatic windows should be deactivated. Dark room should be properly dark. Disconnect the power supply before any cleaning. Should not be connected to an extension cord. External drive to have a regular backup, and a password should used to protect the patient data.
Please try and
For the
conclude,
patient,
Rahul.
electrodes should be attached to the damaged skin. Patient should be explained about the procedure, and waste disposal should be done thoroughly in the household waste. Thank you, sir.
Thank you, Dr. Rahul. And I request Dr. Bharti to talk about EOG. EOG is one electrophysiology test which is not done very, very frequently. And this is useful only for some diseases. So she'll be talking on EOG.
I want to full screen. Full screen kar dijiye.
Yeah.
So good morning, everyone. So my topic today is tips on electrooculogram. So a little brush up before the tips. Who is credited with the first description of EOG? The EOG was described by Elvin Mark in 1951. And the clinical applications were described by Geoffrey Arden in 62. What is the principle behind EOG? EOG is the test to measure standing potential of the eye approximately 6 millivolt. Indirectly, the transepithelial potential that exists between the cornea and the back of the eye. Normal light peak requires normal functioning photoreceptors in contact with the normal functioning RPE. This tests RPE layers and outer retina. What's the physiology behind EOG? First, pre-test requirement is that we keep the patients in the normal room for 20 minutes. After that, we expose the patients to 15 minutes period of dark adaptation. There is a fall in the recorded standing potential, and it typically reaches a minimum at 10 to 12 minutes. This is referred as a dark trough. Following light onset, there is an increase again in the transepithelial potential of the RPE, producing the light rise of EOG. The light rise is ultimately the result of increase in intracellular free calcium, which is released from the endoplasmic reticulum, regulated by an interaction between endoplasmic reticulum bestrophin and L-type calcium channels associated with the basolateral membrane. This intracellular calcium gates the opening of the basolateral calcium-dependent chloride channel. Increased chloride causes depolarization of the basolateral membrane, and which increases the transepithelial potential, recorded as the increase in the standing potential of the eye. What are the prerequisites and instructions? Prerequisites: dilated pupil, pre-test 20 minutes normal room light adaptation, full extraocular muscle motility, good visual acuity, refraction correction not needed, impedance should be less than 5 to 10 ohm. Instruction: head position should be stable, eye movement only in horizontal direction. Never anticipate and move prior. Increase illumination in case of non-dilating pupil, and avoid any bright light procedure like FFA before EOG. How EOG is performed? There is a stimulator called Ganj field stimulator. The two LED light inside 15 degrees left and right of the central light, and it is bright during light adaptation phase and minimum brightness in the dark phase. The pupil should be dilated before testing, and after suitable skin preparation by new prep, recording electrodes should be placed close to the canthi of the each eye. How EOG is performed? For the dark phase, total darkness should be maintained for 15 minutes except for the dim fixation light. For the light phase, a Ganj field back illuminator light of 100 photopic candelena per square meter should be turned on. Continue the recording for 10 seconds out of every minute in each phase. Active electrode is at the inner canthi and a reference electrode at the outer canthi. Ground electrode on the forehead, and impedance should be less than 5 to 10 ohm. Now here you can see the picture, and you can see that the gold cup electrodes is there. It's very expensive. Black is ground electrode, gold cup, blue is reference, and red is active electrode, which is placed near the medial canthi, and it's very important to, the position is very important at medial canthi. They should not touch, there should be separation, otherwise contamination will happen. Patient has to move his eyes to LED with single sweep with head fixed. Circuits recorded 10 to 15 seconds and 50 seconds rest. 15 minutes in dark and 15 minutes in light. Arden ratio. What is Arden ratio? Arden ratio is LPDT ratio, light peak by dark trough. So it is normal is more than 1.8 and abnormally low is less than 1.65. So what are the parameters that should be included in the EOG report? LP by DT ratio, dark trough amplitude in microvolt, implicit time, time from the start of the light phase to the light peak, type of adapting light source, pupil size, and note also any difficulty encountered during testing which may affect the confidence in results such as inconsistent eye movement. What is reliable EOG? Presence of a square and regularly placed waveforms. If waves are not that proper, that means either patient is not fixating properly or electrodes is moving. Light and dark values taken in the respective adaptation period. Typically, जो trough है वो 12 minutes after the start initiation of the test happens, and a peak, light peak happens at the 25 to 26 minutes after the initiation of the test. What is the relationship between the photoreceptors and EOG? RP is relationship we know. Normal light rise in EOG requires a normal RP and good photoreceptor. As the light rise depends on the photoreceptor functions also, patients with abnormal rod functions will have a corresponding reduction in light rise, thus mirroring the extent of photoreceptor damage. So, if ERG is absolutely negative, the EOG will be absolutely negative. Some photoreceptor action is must to have an EOG reading. So, we recommend always to do ERG and EOG together and never in a singular form. A bit. In case of good rod function in ERG, a reduction in light rise in EOG is suggestive of abnormality localized to RP, that is the best disease. Now, a few clinical tips. The most common diagnostic use of EOG is to confirm vitelliform macular dystrophy. Patients with best disease and some patients with adult vitelliform dystrophy have normal ERG but abnormal EOG. Now, you see, this is the bestrophin gene mutated dystrophies. Best, autosomal recessive bestrophin, adult onset vitelliform macular dystrophy, and autosomal dominant vitreoretinochoroidopathy. So EOG is grossly reduced in all except adult AVMD. So EOG is abnormal irrespective of any stage of best vitelliform dystrophy. You can see in one is a not clinical best, and other eye it is a clinical best dystrophy. So, but EOG is more reduced in the eye which has no clinical best disease. If EOG in a child with suspected best disease is difficult to perform, तो आप क्या करेंगे? Test the parents, and one carrier parent will surely exhibit abnormal EOG. Debatable role in differential diagnosis of congenital stationary night blindness, where it is normal from other progressive disorders causing night blindness. EOG is also abnormal in photoreceptor layer disorders, Stargardt, retinitis pigmentosa, cone dystrophy, rod and cone dystrophy. Now, these were all slow oscillation EOG. What is fast oscillation EOG? In 2017, ISF standards have included FO officially. The advantage kya hai ki test time is shorter, making it easier for the patient to be tested. And slow oscillation is recorded during 15 minutes of dark and 15 minutes of light. And on the other hand, the FO of the EOG has the advantage of greater compliance because the total inspection time is 15 minutes. Fast oscillation EOG is different from the typical EOG because that was a square form. This is sinusoidal, different, and mechanism of FO is different from the typical square form of EOG. This happens actually at the apex of RP, near the retina, and not at the base. So fall in subretinal potassium reduces the movement of chloride, and this results in hyperpolarization. And होता क्या है इसमें कि light phase में ट्रफ होता है और डार्क फेज में पीक होता है. यूजुअली स्लो ऑसिलेशन ईओजी में क्या होता है नॉर्मली कि लाइट फेज में पीक होता है और डार्क फेज में ट्रफ होता है. इसमें उल्टा हो जाता है. इसका इंपॉर्टेंस क्या है? Role in distinguishing whether CSC is acute or chronic type, because many a times the patient don't know the exact duration of the disease. In chronic CSC, decreasing RP function is confirmed by decreasing amplitude of the light trough of FOEOG. And FO parameters can be used as indicators for detecting the severity of macular dysfunction, functional disturbance, and predicting the visual outcome for this entity. Thank you. So nowadays, I think it is useful to you. And nowadays, electrophysiology is gaining momentum. And I think in soon near future, it will be very common in the armamentarium of the
Right.
general
Thank you.
ophthalmology
Thank you,
also.
madam. Thank you. And we are happy that Dr. Subhadra Jalali is around us. And no electrophysiology society or conference or forum is complete without her. Thank you, madam, for coming. Thank you very much.
We welcome madam.
So I'll be talking about multifocal ERG and full field ERG. Friends, now you have learned about different kinds of electrodes and the machines and everything. So one of the most important tests that is done in ERG is full field ERG. So you have to take the precaution that you do not do any test of such kind that you put light into the eyes of the patients, like inert ophthalmoscopy or lasers or fundus fluorescent angiography or any for that matter, any examination. You must dilate the pupil fully, and it is better that if you can measure the pupil, because many a times we have to calculate how much light entered into the eye. And the dark adaptation has to be 30 minutes, and if you have done any procedure before that involving light, then you have to further increase the dark adaptation time, probably up to 1 minute or even 1.5 minutes, half an hour. So for full field ERG, the DLT electrodes are the most commonly used, and a lot of people are using even Jerry electrodes. They are the active ones, and the reference electrodes are put in the outer canthus, and the ground electrodes are put in on the forehead. So there are certain tests which are done in the dark adapted area time, and there are certain which are used in photopic conditions. So let's see one by one. If the patient is in the dark and you start stimulating, the stimulation has to be very, very substandard, and please see that there are certain amount of stimulation time, and there are certain strength of the stimulation. See, you have to mark that. We have given you a handouts in which it is mentioned there. So the first test, it is done very, very substandard light, and the interval between the two flash is approximately 2 seconds. And the source of the wave is from the rods, basically, and it generates from the inner nuclear layer. If you slightly increase the flashlight up to 3 cannula, and the interval is 10 seconds, then you can see the A light is a little better, but this is mainly from the rods and little bit from the cones also, because there is light is on the higher side. And if it is the 10 ERG with a stronger flashlight, you get this is also a scotopic, and the light intensity is on the higher side, that is 10 candela, and the interval between the two flashes are 10 seconds. So it visualizes the A wave better. If the light intensity is only 3 candela lights, but the intervals are every 15 seconds, then the waves that are generated are from the amacrine cells, which is at the ascending wave of the B wave. B wave is from bipolar cells. Now the patient is adapted to the light, and then you give the stimulation. Then let's say the patient is light adapted for more than 10 minutes, then a single flashlight is given from 17 to 34 candela. There is a standard flash, and the interval between these stimuli should be more than 0.5 seconds. The source of wave is A wave and plus part of the bipolar cells, and B wave is basically B for bipolar. Then there is a flickering of the lights. This flickering of the light should be more than 30 flashes per second or 30 hertz. It suppresses the rod system because there is no gap in between, so it suppresses the rod system. What you get is only cone bipolar cells stimulations and their waves. It is a more sensitive measures of the cornea. So by this time we know that if you have to check the rods, you go for the dark adaptation test. If you have to check the cones, you have to go for the light adapted tests. So these are the different kinds of waves you get. So we have talked about the photoreceptors, and mind you, this is a full field ERG. So if there is any damage, a little bit of damage, you have to have at least 20% of the damage of the retina to give you any result or negative result. Suppose if the patient has got some problem in the macula, it may come normal. So if you go to the periphery of the retina, you can see there's a lot of rods and cones and a lot of retinal pigment epithelium, then less of rods and cones, and less of bipolar cells, and less of ganglion cells, and then less of axons. So what you do if you go towards the periphery, the scotopic and photopic phenomena, you get the recordings from the photoreceptors, and in the visual evoked potential that tells you about the ganglion cells layers. In the macula, what happens is there are a lot of retinal pigment epithelium, and then a lot of cones, and a lot of cones get attached to a lot of bipolar cells. A lot of bipolar cells get attached to a lot of ganglion cells. A lot of ganglion cells get attached to they send you the axons. So, if you stimulate the macula, you are stimulating most of the cones. So, these are the normal responses. And in a normal condition, what we do is we compare both the eyes, the normal eye and the abnormal eye, that is suspected abnormal eyes. So this is normal in both the eyes. Suppose if there is a case of ischemic ACR view, you want to know whether the patient will gain vision or not. So for the prognosis, you can do this test and you can see that the B wave is the amplitude and the implicit time both are reduced. There are hardly any waves there. In a cone dystrophy also, the cone is gone. All the cone function, all the cone waves are not there. There are many such. We can talk to Dr. Subhadra Jalali and ask her for opinions. There are something like negative ERG also, in which the B wave is little lower than the A wave. They happen in certain conditions. It's there in your handouts. You can go through it. Now, the multifocal ERG is very important. It is a new technology. Initially, it was supposed to be investigative in nature. Now, it is developed by Professor Sutter and Trans in 1992. And your first direct, objective, and topographic mapping was center 36 to 40 degree of retinal function in the center. Multifocal ERG responses are cone-driven. And it tells you about the health of the fovea, parafovea, near peripheral protopic retina can be evaluated. It provides high resolution spatial and temporal information from the retina. There are frame changes and it changes very fast, and these changes are from the CRT monitor. That is, you have seen the checkerboard in the center, it comes from there. So there are a lot of focus in the macular area which gets stimulated. There are approximate somewhere it is 65 to 103 hexagonal stimulus array. They stimulate that area, they pick up the wave, and for this multifocal ERG, you have to have the pupil has to be dilated. The patient positioning should be approximately 35 centimeters from the screen. The fixation point is very, very essential. And you will see in your chart, which I have handouts, that in certain cases you have to dilate the pupil. In certain cases you have to correct the refractive error also. So refractive error has to be fully corrected. The patient should be pre-light adapted. And the stimulus recording, if you suspect some disease, so disease eye has to be examined first, and the impedance level should be less than 10. So impedance level, the machine tells you whether the impedance level is okay or not. If the impedance level is not good, the machine will not proceed further. So you have to correct the impedance. What is impedance? It is noise. There is some problem. So you have to sometimes you have to change the lead. So waveform, they are grouped in a different retinal eccentricities. Horizontally it is 35 degree and vertically is 31, and the viewing distance is approximately 35. The responses are obtained from the 6 zones. So why 6 zones? Because there are a lot of toxicities of the diseases of the drugs, which are they show the abnormality in the 2nd zone, or sometimes it is 3rd zone. And since it is a topographic mapping, so it makes your life very easy to understand whether this is normal or not. So it is always compared. On the right hand side is normal, the left is diseased one, and Stargardt's disease. So it also gives a wave, the positive wave and the negative wave. The positive wave is the P wave, and negative is N1. And you can measure the implicit time in milliseconds and response in nanovolt. But we do not calculate that. It is the mathematical summation, and the machine gives you the overall picture. So friends, if you do have to check macula, multifocal ERG tells you the cone system function at the macula, because there are a lot of cones there. And the other function at the macula could be PERG, that is the pattern ERG. that tells you about the some amount of receptor cells and about the ganglion cells layer. With Dr. Vibhuti will be talking about it. So, what is the application of the MFVRG? That is macular dystrophies, central serous retinopathy, drug toxicity, inflammatory conditions, and this again chart is given to you in your handouts in different conditions. What should be the refractive error and visual acuity, etc. And what are the waves to be observed? People have talked about so much. What are the waves? In full field ERG, you have to observe wave A, B, and C. In flash VAP, you have to see N2, which is very important, which is approximately 100 millivolt. The implicit time should be 100. And in pattern reversal VEP, P2 is important. In EOG, Arden ratio is very important. And in PRG, N50 and N95 are important. So if you suspect certain diseases, what all tests should be done is there in the handouts. That is very, very important. So this is one of the normal ones. So it looks normal. On left hand side is the eye which was tested, and by just a glance you see that it looks normal. So thank you very much, and I request our next speaker, Dr. Vibhuti. Yeah.
A very good morning, everyone. And at the onset, I would like to thank Dr. Subhadra Jalali ma'am for gracing our IC with her presence. So continuing with the IC, my topic is pattern ERG. So first up, what are some retinal disorders that are most likely to be confused with an optic nerve disease? Something like a subtle posterior scleritis, central serous retinopathy, Azures, old CRAOs, cone dystrophies, AIRs, autoimmune retinopathies, paraneoplastic, etc. So this is a study done by Dr. Graham Holder in 2001. He had a large case series where he showed that if we do just a visual evoked response, the P100 changes are not actually specific for a neuropathy. It's not specific, and it does not tell you whether it's because of a neuropathy or a maculopathy. And he also showed that the changes in the P50 wave of pattern ERG are a much more sensitive tool to diagnose a maculopathy. And that's where the use of pattern ERG comes in. It enables an optimum pattern VEP interpretation. This is an example borrowed from him. This was a case of a 30-year-old man who presented with a decreased vision in the left eye. The ocular examination was non-significant, and a pattern VEP showed a reduction in the P100 wave. So the instant diagnosis was something on the lines of an optic neuropathy. But when this patient was subjected to a pattern ERG, there was a reduction in the P50 wave, defining it to be a maculopathy, and later on the OCT revealed a subtle posterior scleritis. So then what exactly is a pattern ERG? It basically is a tool to assess the central retinal response to a structured non-luminance stimulus with the help of a temporally alternating black and white checkerboard pattern, and it is useful to distinguish between maculopathy and neuropathy. In this investigation, the net retinal illumination remains constant. There only is a redistribution of the pattern of the light and dark area, so called the isoluminant pattern reversal. 3 types of waves are formed, but broadly remembering there are 2 types of waves that are really important for us: a P50 wave and an N95 wave. A P50 wave arises 70% from the ganglion cells, but are actually driven by the macular photoreceptors. And N95 comes from the ganglion cells, and they're the negative waves. So in a maculopathy, the P50 wave goes, and in an optic nerve dysfunction, the N95 goes. So what are the types of ERG? There are two types of ERG. Pattern ERG, the transient type and the steady state. For practical knowledge, just remember that we implicate the transient pattern ERG because they have lower temporal frequencies of less than 6 reversals per second, and they allow for a reliable peak detection, so detection of P50 and N95 is possible. As discussed before, the patients are positioned at 1 meter. They are light adapted with pupils normal sized, non-dilated. Fixation is important, so the patient should be able to fixate. Excessive blinking has to be avoided, and the refraction has to be appropriate for 100 centimeters. This is how the stimulus looks like, and the mean width and height of the stimulus is 15 degrees, and the check size is of 0.8. This is how the stimulus interface in our machine looks like with a red cross of fixation target. The luminance has to be constant, as I discussed earlier. There has to be a high contrast of more than 90%. The reversal rate is lower, approximately 4 reversals, and the frame rate of more than 75 Hertz. The electrodes are the usual that has been discussed before. The DTL electrodes are the one that we use in our practice, and the reference electrodes and the ground electrodes. These are the channels discussed before. I'm not going to go through it again. This is how we place the electrode for pattern ERG. The active electrodes are fixed on either canthi. The reference electrode just beneath the outer canthi, and the ground electrodes on the forehead. And this is how the patient is made to sit in front of the stimulus. These are the gels, the new prepped skin gel and the 1020 conductive paste used to clean the skin and apply the electrodes respectively, just going through so that it brushes the electrodes again for you. This is the short manual that is provided with each machine, with the machine to us, and these have the guidelines as to how to proceed with the pattern ERG evaluation. So when we open up the software, this is how the software interface looks like. We click on the patient, and then it gives us the array of choices as to what investigation exactly you have to do. So we click on the pattern ERG and click on the patient's name fed. This is the examination interface. This is how it looks like. Now when we look at the bottom right corner, we see the box of impedance. When we click on that, this box pops up. So it basically shows us what exactly is the impedance level of each electrode. So the impedance level ideally should be less than 5 kilo ohms. Now how do we achieve that? With proper cleaning of the skin and proper application of the gel. And we keep on doing that till we achieve all 4 green signals. And then we start the examination, and then we stop the examination, and then we click on the analyze button, and this is how the waves look like. Now do these look like a proper P50 and N95? No. Why is that? Because these are very small amplitude waves. And if you notice, the divisions over here are of 50 microvolts per division. So we reduce the scale size to a 5 microvolts per division. This is the maneuver that you have to do while you're examining. And when we do that, we see in for the left eye, we get a very proper P50 and a normal N95 wave. Similar is not the case with the right eye. We get a very erratic wave over here. So what can be the cause? So we go back and check the impedance value, and we see that in the right eye, the active electrode's impedance is high, and that is the cause for an erratic wave. So we correct that. So this detail is not required for us. So what all does the pattern ERG reporting should contain? It should contain the measurement of amplitudes. Can I have the laser pointer? Yeah. So this is the normal printout of a pattern ERG. So what all should it contain? It should contain the normal waveforms of P50 and N95. It should contain the normal values of the various variables that we are measuring. And what are the variables we are measuring? We are measuring the latency and the amplitude of P50 and N95. So the actual values, the normal values, and the waveforms are something that should be incorporated while we are giving the printouts of the reports. Now, where and all can we get an abnormal P50 amplitude? As I said, the abnormal P50 amplitude comes from abnormal macula. So subtle macular edema, central serous retinopathy, hereditary retinopathies which affect the macula, they will be causing an abnormal P50. Abnormal N95 will come in an optic nerve dysfunction of either type, either a glaucomatous nerve or a neuritis or a hereditary optic degeneration. So pattern ERG is always a supplement to visual evoked potentials and ERG, and various types of permutation and combination of results gives you various types of diagnosis, which usually in routine practice as retina surgeon or as general ophthalmologist we club into one. Of note is that pattern ERG is also detectable in no PLIs, and it can also help you distinguish a central macular dysfunction from a peripheral macular dysfunction. For example, if the central pattern ERG of 15 degrees is abnormal, and if we increase the field to 30 degree and if it regains its normal amplitude, then the central field, the central macula is the one that is affected and not the peripheral macula. What are the uses of pattern ERG apart from this? So it can help in early glaucoma detection in the pre-perimetric phase, or in ocular hypertension when we want to know if the disc is getting damaged and if the nerve is getting damaged or not. It can be used to monitor drug toxicities, and it can also be used to monitor therapeutic success of various drugs in various retinal pathologies. Thank you.
Thank you, Dr. Vibhuti, for finishing in time. Our next speaker is Dr. Nidhi. She'll be talking about VEP. In most of the places, if they are doing electrophysiology, the VEP is always there.
Good morning, everyone. Thank you, sir, for making me a part of this IC. I have no financial interest. Now, VEP measures the electrical signal generated at visual cortex in response to visual stimulation. The occipital responses corresponding to the central visual field are measured, and it assesses the intracranial visual pathways and their functional integrity right from the retina to the optic nerve, optic chiasma, optic radiation, and occipital cortex. Now, the peripheral retinal projections are within the calcarine fissure, but the central retinal projections go to the occipital lobe. The foveal projection is magnified at the cortex, and at the fovea, the linear extent of the cortex is around 5.6 mm per degree, while 10 degrees away from the fovea, it becomes only 1.5 mm per degree. So what are the indications of VEP? Optic neuritis, multiple sclerosis, optic atrophy, hereditary optic neuropathies, toxic neuropathies, traumatic brain injury, compressive optic neuropathy, glaucoma, amblyopia. Additionally, it helps us to evaluate any unexplained visual loss, malingering, pre-surgical evaluation and prognostication of cases, and measuring the visual acuity in non-responsive subjects. So the requirements here, we'll have an active reference and ground electrodes having impedance less than 5 kilo ohms. The active and reference electrode impedance difference should be less than 20%. The placement of the electrodes follows the 10-20 rule, in which the whole head is divided from the nasion to the inion in different parts. The active electrode is placed at OZ, the ground electrode is placed on the top of the head, and the reference electrode is placed at point FZ. Now, this is the recording interface showing the difference in resistance between impedance between the two electrodes is not okay. Now, the stimuli of the VEP can be flash, pattern, color, or motion. Most commonly used in flash VEP, we have the Gansfield stimulator, and in pattern VEP, we have the CRT monitor. Now, pattern VEP is the most commonly done test done in patients having good visual acuity. The patient should be light adapted and sitting at 100 centimeter with correction done. Pupil should be undilated and has to be done monoocularly. Flash VEP indications are same but done in patients who have poor visual acuity. The eye is light adapted, dimly illumination, the room should be dimly illuminated and done monoocularly. Pattern onset and offset I'll be talking on later. For pattern VEP, the requirements, we require a checkerboard pattern. Here the pattern is reversed and we have different checker sizes, 60 minutes or 1 degree and 15 minutes. The luminance has to be constant and the contrast needs to be high. In flash VEP, it should correspond to a field size of 20 degree and at least one flash per second, that is 1 hertz. Flash intensity is low, 1.5 to 3 candela per meter square, and the background intensity is also 15 to 30 candela per meter square. Now, pattern VEP is done for investigation of optic neuropathy. Additionally, flash VEP will be done in patients having poor optics, poor cooperation, poor vision, and where pattern reversal cannot be done. Pattern onset and offset VEP is done in patients having nystagmus, malingering, or amblyopia. Coming to pattern VEP once again, this is the checkerboard stimuli. The pattern is reversed, alternate black to white and white to black. And we have to look at the artifacts like blinking of eye, the lesser the better. The total number of tests done at least should be 64, and these tests are repeated at least twice. In infants or patients having less attention span, the number of tests per test can be reduced. Now, the check sizes subtending 15 minutes of arc are the best stimuli for testing foveal vision. And checks of 60 minutes or 1 degree are superior in evaluating the parafoveal vision. Therefore, using more than one check size increases the diagnostic yield. If the resulting VP using the larger check is poorly performed, then we have to use again a larger check than that, or use a pattern onset stimulus. Now this is the waveform that is seen. The most important wave here is the first positive or P100 wave. The amplitude of the P100 is calculated from the trough of the N75 to the peak of the P100, which should be more than 5 microvolts. And the latency is normally from 90 to 110, varying from lab to lab, but on an average is taken as 100. And this is how the report is given to the patient. Few examples of pattern VP. This is the normal waveform in both the eyes, showing normal latency and amplitude. This case is that of a traumatic optic neuropathy in left eye. There is delayed implicit time and reduced amplitude versus the right eye. In cases of AION, the implicit time here is normal, amplitude is reduced, and the waveform has become wider. Optic neuritis in the right eye, there is a delayed implicit time versus the left eye and moderately reduced amplitudes. This is a case of optic atrophy with no PL, and no signal in the left eye could be elicited. Now, a VEP can also be used to measure the progression of optic nerve gliomas in cases such as neurofibromatosis. There will be increase in the latency of P100 in both the optic nerves with progression of the gliomas. In cases of toxic neuropathy like ethambutol toxicity, here the latency of P100 will be increased. Coming to pattern onset and offset VP, here the pattern is flashed on and then off. So 200 milliseconds it's on, followed by 400 milliseconds of off equiluminant diffuse background. Here also we will have two check sizes. The pattern onset or pattern flash stimuli produces a more robust VP than does pattern reversal in the central 30 degrees. And this is the comparison between pattern onset offset and pattern reversal. Here, first it is on, and then there's an offset, and in reversal, the checkerboard pattern changes from black to white or white to black. Now, pattern reversal stimuli usually exacerbates nystagmus and interferes with the ability of the eye to maintain foveal fixation. Thus, this is better in testing patients having nystagmus. Pattern onset stimuli can also be the most productive stimulus for monitoring amblyopia. Pattern onset stimuli is less sensitive to poor fixation, eye movement, and deliberate defocusing using, thus it is useful in examining patients that might be malingering. So this is the waveform. Here the second wave or C2 is the most important, which might have a latency of 100 to 120 milliseconds. Flash VP, here the stimulus is a flash. Field side should be at least 20 degrees and 2 measurements need to be done. Indicated in uncooperative or unconscious patients having media opacities, prognosticating of eyes with poor vision before planning any surgery, and monitoring the visual function of babies. So VP is often prognostic in delayed maturation of the visual system. Usually the infant with delayed maturation has a normal flash VP, whereas permanently cortical blind infants might have abnormal VPs. This is how the recording interface looks, which needs to be enlarged according to the voltage. Here, the P2 latency is most important, which is 100 to 120, and the N2P2 amplitude should be more than 10 microvolt. Just a note on sweep VP, to be done in infants, suspected malingers, or disabled subjects. Here, the visual acuity is extrapolated in logmar units. Multifocal VP are not that commonly done. Here we have 4 active electrodes in a mounting bracket, and they give corresponding waves, which can be in a sectoral pattern or a ring pattern. This is the normal multifocal VP in both eyes. Right eye is red, left eye is blue. In optic neuritis, if you see, initially the red is extinguished in the center and abnormal in the central 30 degrees. And over time, there is significant recovery in the amplitudes, but slower peak times due to demyelination. This is the output in unilateral glaucoma. Just reviewing all the waves of all the VPs. That's all from my side. Thank you so much.
Thank you, Dr. Nidhi. So, do we have any questions?
Renu madam, Vinay sir, Chairman Scientific Committee, AIOC. We all appreciate your presence.
So, in that case, I'll request Madam to say a few words and conclude the session. And we have 5 minutes for her. And then I'll request Dr. Sanghamitra to have her paper on keynote address.
So Dr. Sanghamitra, are you here? Is she here? Not yet. Okay, I'll just take 5 minutes about ERG. I think for me, visual electrophysiology, I got trained in NEI at USA in 1995 because we were doing a project on genetics of RP in India with NEI. And I was really fascinated because there was no learning here. And I can tell you that being an electrophysiologist, I can see many things which so many of my colleagues and seniors cannot see. And of course, it is my backup plan. The day I stop operating, my hands start shaking. I'll still be an expert on electrophysiology and I can diagnose patients and treat them. So that even if I'm in a wheelchair, I can do it. So it's a beautiful science. I think those who are really seriously interested, you should become members of ISEV. ISEV is the International Society for Clinical Electrophysiology of Vision. Even if you're not members, they hold an annual course. Their main aim is that people should clinically do this work. So they are not interested in theory, they are not interested, because there's a lot of electrophysiology in animal world, in pharmacology, in drug toxicities, in cell cultures, but they are interested in clinical electrophysiology. And they do beautiful hands-on courses, which is 1.5 days. We also held one here in 2007. And this year it is in Liverpool, and it will, every year it goes from one continent to other, so it will come in a continent or a place nearer to you, so that you don't have to travel far away. So every year it will go from America to Asia to Europe, Africa, and then back to America, Asia. So this year it is in UK, like in Liverpool, and next year it may be coming to this part of the world.
So how to become a member of ISEF?
You just apply to them. So that is like if you go to the website and just like you become member of American Academy, any academy. So those courses are very good. That is one. Second is we also have in our hospital 1 month's hands-on course for people who want to do that. Basically, we teach you how to do the test and all. If you have a machine yourself and you are hesitant, you can call the company people and do your own ERG, your own VP. You will learn a lot if you do your own test and you will understand. Actually, nowadays the machines are very computer oriented, they are automated. Most of the tests are automated. So the testing is not very difficult, you can learn it. But the interpretation requires you to get well trained. Otherwise, it's not like OCT where you can see like a histopathology and you can judge. Because you are used to seeing histopathology sections, so you know what is a histopathology. So even if somebody doesn't tell you that there is a cyst or there is a edema, you can make out that this is not a normal OCT, there is something abnormal. But in VP, ERG, we don't have much of training, right? So I think it's very important to get to a master and be with them for a month or for that course. I did that course 3 times before I could really sort of get a hand something, although I was already trained as an electrophysiologist. And even now, like, if I want to do more advanced, then we keep on calling people to train us. There's also an Indian Society of Electrophysiology where we are holding our annual meeting. Neha Goyal is there, I'm there. So anybody who wants to become members of the Indian Society and learn some more, we are happy we have a group. So we also sort of teach and learn. Yeah, we are organizing our, last year we organized webinars. Before pandemic we had 2 meetings, one in Neha Goyal's hospital and one in Bhubaneswar. So we will be holding possibly this year or next year the next meeting. So although the opportunities are few, and tomorrow also morning I have a course on electrophysiology, so you can attend that. Yeah, so be serious about this topic because it's really, really helpful. It solves so many problems that the patient comes to us and we are not able to explain or we are not able to understand, and then we keep on referring them from one place to another, and this is a very non-invasive test. I don't do FFA in my CRVO patients. I do only electrophysiology because for me those patients are sick, they're cardiac patients, they're, you need to get physician's clearance and all, and the ERG tells me what the FFA doesn't tell. So it has its own advantage. Of course, it will have its own, fallacies if you don't know the test, but it's a very powerful technique. It's not a It's like the ECG. I mean, you can't imagine that you go to a cardiologist and he will not do ECG and then he will not know how to read your ECG. Right? The ECG is first thing. You don't go and do treadmill and echo every time. You do an ECG the moment you have a pain. And that gives so much information. So same way, I think we have neglected electrophysiology for many years. We should get hands on it. All of us can do it. There's nothing great about it. Just like people do ECG, they do, nerve conduction. All the neurologists do nerve conduction.
Common ho jayega.
So once we put our minds to it, we all can become experts. It's not difficult. And we may not have our own ERG, EOG equipment. They could, like in Hyderabad, we have one technician who's my technician only. He went and set up his private center. So people send the patient there. He does it. He makes some interpretation, but then the clinician interpretation would be a little different. Experts.
Means in future everybody will become more aware about the importance and baseline importance. ये नहीं कि सबसे पहले CRVO का पेशेंट है तो FFA कर रहे हैं.
नहीं, first we have
electrophysiology तो करना ही है.
First we have to understand what is the test showing us, how it is done, what are the interpretations. Simple interpretations are there. We also had the hands-on course in the SSTC. Every year in your DSTC, whatever it's called.
Diagnostic transfer test.
So every year I'm holding 2-3 slots. I love to teach electrophysiology, so you can join that course also. So there, at least in AIOS, there are opportunities now to learn the electrophysiology. So I think you did a beautiful course. The basics were very nicely presented. That these are very simple things, simple waveforms. It was very nicely, correctly presented of what we are talking about. But I think we need to get hands-on.
Ma'am, we all the instructors, we want to honor you as our
We would like
special
to honor
guest.
Dr. Subhadra Jalali to have spared so much of
Madam,
time,
कुछ हम लोग एक
and
झारखंड
so
से कुछ लाने
token
से
of
नहीं
love
आना
from
चाहिए।
Jharkhand.
I think we should take a picture, that's the best.
Yes.